Welcome, everyone. Welcome to the second HCP Rounds. And we are joined here today with Dr. Glenn Hernandez, intensivist out of Chile and the principal investigator of the Andromeda Shock 2 trial, which we're going to be talking about throughout the webinar. Um, as always, if you have questions, feel free to pop them in the Q&A and we'll get to them when we can. First, I just wanted to thank our sponsor again for HCP Rounds, Flowsonics. If you don't know, Flowsonics has produced the world's first wearable ultrasound patch that can actually measure carotid blood flow and jugular blood flow. The corrected carotid flow time is a surrogate of stroke volume, and the jugular flow can show you a marker of venous congestion by looking at the waveform. And this is really relevant when we start talking about things like venous arterial assessments. And so this was a paradigm, the Doppler Starling curve that was proposed, where on the y-axis we have a surrogate of stroke volume, and on the x-axis we have a surrogate of congestion. And similar to that Diamond-Forrester classification that was produced for heart failure, where there's the warm and dry, warm and wet, cold and dry, cold and wet, we can kind of place any patient with shock into these categories. And if you can quantify their stroke volume and congestion status, you can predict their likelihood of being fluid responsive, but also get an idea about how they're going to respond to other therapies, decongestion and inotropes. And this was actually borne out looking at rates of fluid responsiveness using flow patch. And so if you look on the y-axis with corrected carotid flow time, you can see that patients in quadrant 1 and 2 have a slightly higher likelihood of being fluid responsive. Quadrant 1 and 3 have a higher likelihood of being fluid responsive. And then patients that are congested on flow patch, looking at the jugular venous Doppler, are going to be less fluid responsive. And so really, and certainly something that we talk about a lot on HCP rounds is phenotype resuscitation and integrating these different concepts of forward flow and congestion. And flow patch is a great way if you are doing that at your shop. And so, yeah, so thanks again, Flowsonics, for supporting us here. It wouldn't be possible without them. All right. And with that, let's talk a little bit about microcirculation, which is what we're going to be talking about today with Dr. Hernandez. And so the first thing I want to start with is, why do we care about microcirculation? And if we hold a mirror onto all of ourselves here in the audience today, we're all fluid responsive right now. That's a normal physiologic state. Similarly, none of us have venous congestion, and all of us are very fluid tolerant. Yet none of us are hooked up to IVs right now and getting fluid boluses. None of us need that. And the reason why is that our organ perfusion, our microcirculation, is normal. And really, our attempts at resuscitation should be designed to improve organ perfusion at the very core. Because again, everyone is fluid responsive. Everyone is fluid tolerant in a healthy physiologic state. So this has led many of us to adopt what we call a microcirculatory first approach, where we start with some sort of assessment of microcirculation. And if that is abnormal, then we start looking at macrocirculatory parameters, stroke volume, fluid responsiveness. And then we ask ourselves, is the patient fluid tolerant, or will they be harmed by IV fluids? Things like venous congestion, or looking at the acute illness, heart failure, cardiomyopathy. The problem is, it's really tough to assess the microcirculation. Even this diagram here is completely made up. It's an animation because it's very difficult to look at what's happening at the organ level. So we really rely on surrogates of the microcirculation, things like capillary refill time, assessing for modeling, lactate, which we know has both aerobic and anaerobic pathways that produce it, and other microcirculatory markers like urine output. And Dr. Hernandez actually led the Andromeda Shock randomized control trial that was published in JAMA in 2019. And they compared lactate-guided resuscitation to cap refill-guided resuscitation. And so essentially, if a patient had abnormal cap refill, you would then intervene on that with some sort of maneuver to try to improve microcirculatory health. And they showed that there was actually likely a benefit to cap refill-guided resuscitation over lactate-guided resuscitation. Now, if you look at the p-value is 0.06. So from a frequentist perspective, many people would say, well, that's a negative trial. But certainly when you approach it with a Bayesian mindset, and what many of the experts in the field believe, that this does support that cap refill-guided resuscitation is a very viable approach to resuscitating patients with septic shock. This led to the Andromeda Shock 2 RCT, which is ongoing, and really exciting that we have 75% of the patients recruited worldwide, which is an incredible feat across over 100 centers, I think, worldwide, which is just huge. Kind of hats off to Dr. Hernandez and the rest of the investigators of the study here. But really, this is focusing on cap refill at the core of the resuscitation paradigm and only doing interventions if the cap refill is abnormal. So you can see at the start here, we start with abnormal cap refill. If it's normal, don't do anything, just monitor, because you can't get better than normal. Then if it's abnormal, that's when we go down this pathway and start looking at things like pulse pressure, diastolic pressure, norepinephrine challenges, fluid responsiveness. And so really kind of with this in mind, that at the core of a resuscitation paradigm is capillary refill, I'm going to hand that over to Dr. Hernandez, and let's kind of hop into the discussion here. So Dr. Hernandez, thanks again for joining us. And why don't you tell us a little bit about cap refill time? Why is this the perfect surrogate for microcirculation? And how does this actually compare with the organs that we really are focused on? Because we don't really care how the skin is perfused, but we're using it as a surrogate for other organ perfusion.
Yeah. First of all, thank you very much for inviting us. Do you think I can share a couple of slides?
Yes, please.
Yeah. Okay. Thank you. As you mentioned well, Ross, the process of resuscitation is in general to perform an active macrohemodynamic manipulation. The things that you mentioned is cardiac output, mean arterial pressure, which is the perfusion pressure. And to manipulate cardiac output, you assess fluid responsiveness. I hope that in the future you add to this the risk of fluid or the concept of fluid tolerance, so et cetera, et cetera. But these are tools that this active macrohemodynamic manipulation is just with the idea or the goal to restore tissue perfusion. And then it is complex to assess tissue perfusion because we, in general, we use perfusion surrogates. And this is, I have an earlier slide, which is very interesting to understand this, because this is always the play, what we do in actual clinical resuscitation is to manipulate macrohemodynamics. I mean, manipulate the determinants of cardiac output on systemic blood flow and mean arterial pressure, which is the perfusion pressure. These variables are easily measurable. You can easily assess cardiac output now with many devices, less and less invasive along the years. And mean arterial pressure, it's relatively easy to assess also. And you manipulate because cardiac output is systemic blood flow, as I said, and mean arterial pressure is the perfusion pressure at the end. You know? So in patients that arrive with sepsis-related hypotension or just have developed full septic shock, in general, you start to manipulate this and to push, let's say, perfusion with the hope that it arrives to the cells that oxygen demand, et cetera, et cetera, et cetera. But this is just a wish, you know, a sort of, let's say, faith-based medicine. You manipulate this with the tools that and the instrument that we always had with fluids, vasopressors, and inodilators, with the hope that it gets to the cell. But this is a totally complex and more complex process because after this, you have to, this flow is distributed, and then it has to go to the microcirculation, where it has to be the exchange of oxygen, PCO2, et cetera, finally to the cell, finally to the mitochondria to maintain oxidative phosphorylation and production of ATP, et cetera. So it's a long chain. And the problem is that in contrast with the macrohemodynamics that you can so easily assess, how do you assess distribution? How do you assess microcirculation in the cytoplasm? Is this at this level? Is it not enough or whatever? The ATP, let's say, supply, it's not enough, etc. So you have to use surrogates to evaluate this. And surrogates that in general are, let's say, evaluate some physiological aspects. Some of these surrogates that we use are compensatory mechanism. For example, the SCBO2, which is the balance between DO2 and BO2, you know? And others reflect also a compensatory response. For example, the behavior of the peripheral perfusion, the skin, when you have a circulatory crisis, the adrenergic response takes away blood flow from the skin, and there is a local vasoconstriction that produces a profound hypoperfusion in the skin and also in the hepatosplanchnic area. And then this flow goes away to redistribute to other tissues or organs like the heart, the lung, etc., the muscles. So these are indirect variables, surrogates, that on which you can assess, let's say, indirectly how the perfusion is. So it's always a relatively, let's say, you have to make many assumptions, you know, and there is no surrogate that is perfect. If I go further on here, this is a concept that was developed by one of the best physiologists still working, is Michael Pinsky, which he called circulatory effectiveness, meaning that when you have a circulatory crisis, a shock state or some sort of circulatory dysfunction, you have to push macro hemodynamic variables. I mentioned already flow, cardiac output, pressure, mean arterial pressure, etc., to preserve and restore perfusion and maintain organ function. But how do you assess, and this is what you asked, Ross, the adequacy of flow? And then you have several variables that have been called in common language at the bedside, the perfusion variables. But they are quite different, you know. SpO2 is it's just the relation between oxygen transport and oxygen demand in the superior vena cava in general area. And if, of course, you have a decrease in systemic blood flow, you increase extraction as a compensatory mechanism, and then allow SpO2 reflects this process. But it has its drawbacks, of course, because in patients who had a severe microcirculatory dysfunction where oxygen extraction takes place, you will have a normal or supranormal SpO2, but in parallel with profound hypoxia, because then all these variables have drawbacks. The PCO2 gap reflects microcirculatory flow, meaning that when you get a hypoperfusion at the microcirculatory level, for example, let's say imagine some values, for example, cardiac output decreases by 1 liter, and you have a normal offer of PCO2 in the microcirculation, then it takes it out to the lungs, and then you have a normal circulation there in the microcirculation where the entrance PCO2 in the arterial side is 40, and the venous side goes back to the heart with 46, let's say. But when flow is low, for example, instead of 1 liter of flow, you have 500 ml, then the PCO2, which diffuses very rapidly, the physiologists have called this process the PCO2 stagnation, gets there stuck in the microcirculation. So when you have half of the flow returning to the heart is the double saturated in PCO2. So you have a PCO2 gap that increases, the PCO2 in the venous side increases to 50, 55 because of this low flow. So it's inversely proportional to the cardiac output. So it gives you some clues about how systemic flow is running. Lactate is very complex. I will not get into detail because it has Ross already mentioned, it has hypoperfusion-related sources. Of course, anaerobic glycolysis, which is a compensatory mechanism when flow is low, but also many non-hypoperfusion-related sources. Particularly one is very important, the adrenergic response, which induces lactate production in the muscle for metabolic function, metabolic shuttle, signals, etc. So it can be very confusing to follow lactate. In addition, it has a very slow recovery, even if you resuscitate the patient, because it has some metabolic components, so it's complex. And peripheral perfusion is more honest, I would say, because when you go to this slide, I will finish in a minute. Peripheral perfusion is more honest, I say, because it does not have almost auto-regulation compared to other territories, has no metabolic control, is most strictly flow and sympathetic control, meaning that if you get, let's say, decrease in cardiac output or you get hypotension, you enter in shock, immediately the adrenergic tone increases and takes away the flow of the skin and redistribute it to other places. And then you have, for example, a cold, clammy skin with mottling and a very prolonged capillary refill time. And when you restore central hemodynamics with fluids or vasopressors or inodalate or whatever, early on, usually with fluids or vasopressors, then adrenergic tone decreases, flow increases, and then you can see in minutes, believe me, and you know, in minutes, a transition from a cold, clammy skin to a warm, vasodilated one with disappearance of mottling and a rapid recovery of capillary refill time, this technique. So we have been using capillary refill time for around 15 years at the bedside. Have done a lot of research on this, but only some years ago, a couple of years ago, I started to think 4 or 5 years ago that when you witness this transition of the skin, what you are looking at is the ischemia reperfusion in real time. I mean, it's a very nice surrogate of the ischemia reperfusion just visible under your eyes. So it's very nice and it's costless, universally available, etc. And one question that you said, Ross, is if this is representative of other territories. And what I can say to start with is that, of course, I said this sympathetic control of the skin blood flow, no? But, and why is this neurohumoral response is not only epinephrine or norepinephrine, it's just also angiotensin, vasopressin, blah, blah, blah. There are other components of the sympathetic neurohumoral response to a circulatory crisis, of course. But in the skin, the most powerful is adrenergic tone. But, and this will interest, of course, Eduardo Argaiz, there is another territory that is profoundly affected by this response, which is the hepatosplanchnic region, which you agree with me that probably is much more important than the skin, of course, physiologically, pathophysiologically, etc. So what I always say is, if you have a cold, clammy skin and you resuscitate, and then the skin in 10, 15 minutes after a fluid bolus or after restoring mean arterial blood pressure makes this transition to a warm, vasodilated, and capillary refill time tends to normalize, you have good chances that the hepatosplanchnic region follows the same direction. Maybe not the same kinetics, because the hepatosplanchnic region is more complex, has more regulation, more actors, but it will follow the same direction. And you have good chances that will happen. So this is why, from the epidemiological perspective, normalization of the skin is associated to such a good prognosis. It's not about the skin, it's about what it represents. The microcirculation of the skin is also the microcirculation probably related to hepatosplanchnic, blah, 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 the same regulate. And the inverse, I always tell my students, my residents, the inverse is most stronger. If you try to resuscitate the patient, give fluids, vasopressor, inodalate, or whatever, and the skin maintains it maintains as a cold, clammy skin with no recovery, nothing, then would you bet for the fate, would you bet for the perfusion of the hepatosplanchnic region? No way, no. It's no way that the skin is black, cold, no capillary refill time, mottling 5, and the hepatosplanchnic region is smiling, it's okay, blah, blah, blah. This is you cannot imagine. And this is interesting because the hepatosplanchnic region is a black box, you know. We have some organ blood flow with ultrasound now. There are some things, but it's not so easy to assess, you know? So it could be an indirect marker of what is happening in more relevant physiological tissues. And this is the only way I understand why, from the epidemiology, so many studies telling you that when the skin recovers rapidly is associated with an excellent prognosis. If does not, the prognosis worsens a lot. From a physiological perspective, we have some studies, small studies that show that the skin moves in parallel with other tissues. And there is this Andromeda shock study, you know that. So
Yeah, well, actually, you mentioned I'm very interested in hepatosplenic, but also in renal perfusion. And you mentioned ultrasound to measure flow in this region. So I would say I would be very cautious about using ultrasound to measure flow. So what we're like most of these studies, what they're really using is a pulsatility index or
pulsatility,
index, which is this is influenced by many different variables, including pulse pressure and other variables that do not necessarily reflect flow. And I don't think we have a gold standard that's easily accessible at the bedside to assess organ perfusion, except for urine output, which could be again influenced by many different things, such as acute tubular necrosis or other stuff. So I do think capillary refill is actually the gold standard for perfusion, not only in the skin. I mean, it's a surrogate of perfusion in the whole organism. And that's why, I think if we're doing this, I mean, in our shop, everybody's doing capillary refill time. And I think that's mostly thanks to your trial. And I would like to take advantage that you're an expert and in doing this, and you have standardized the technique so that it's done every time with the correct time of pressure, the correct way of assessing it. Are you using chronometers? Are you using a special technique? Could you guide us through the process of how you standardize this and how is it done at the most professional expert side of capillary refill type measurement, which is your place?
No, and I would say that first that concerning your comment, Eduardo, I was when I was young, when I was starting as an intensivist in the late 90s, I'd say, I had the opportunity to work for some years with gut tonometry. And gut tonometry is another thing, I am a widow of gut tonometry because it was a very simple, and like an NG tube, modified NG tube, which assessed PCO2 production by the superficial mucosal cells of the gut, the gastric layer. And when it increased, it meant that the hepatosplanchnic was getting hypoperfused, and then it was a wonderful tool. And unfortunately, it was lost over time. And since gastric tonometry was killed by the industry, I don't know the reason, don't ask me because I get angry. I have had no other such nice perfusion-oriented monitor available, except as you say, urine output and etc. So capillary refill time is very nice. It represents flow, but if you think about it, it's also a vascular occlusion test. The vascular occlusion test that you can use with NIRS, looking at what happens with the post-ischemic hyperemia, which reflects a normal endothelium after a short period of occlusion with the cuff compressing all the flow to the upper limb, to the lower limb. The vascular occlusion test with NIRS or with the laser Doppler of the skin, and you look at the curves of when you stop this compression in 3 minutes, you look at the reperfusion, at the reoxygenation in the case of NIRS, and the increase in skin blood flow in the case of the laser Doppler. We have done both, and they show you if the endothelium is in the indemnity of the endothelial function. So the vascular occlusion test, if you think about it, is also a small vascular occlusion test. So when we discuss this around people that are interested in capillary refill time, we always conclude that it's a little bit more complex than flow. It also reflects to a certain degree, maybe endothelial dysfunction and vasoreactivity, etc. But we have not enough studies to say this for sure yet. So concerning the technique, it's interesting because one of the criticisms over capillary refill time is that it's inter-rater reliability, variability, etc. So we standardize the technique in Andromeda Shock. We use a microscope glass slide. We compress the ventral part of the index finger until it gets completely blunt. And then we sustain this compression for 10 seconds with a chronometer, usually from our mobile phone. We sustain to make a prolonged vascular occlusion test, and then we release, and we expect that the color of the oval of the ventral surface of the index finger recovers completely, and then it should be, we use the pragmatic number of 3 seconds with the decimal. Why use the microscope glass slide? Because people with different strength, with different force, they make the same compression, the compression enough to make this blanch, otherwise when you use your fingers, it's cannot be equalized, it cannot be homogenized. This is the way to homogenize the compression, and then with the chronometer is quite easy to assess. This is the technique we used in Andromeda 1, and we are using in Andromeda 2. I mean, I don't know in Canada and in Mexico, but in Chile, you can buy 100 of these slides for nothing. I mean, less than $10. I mean, they are very cheap. And all my residents have one in the pockets, and then we have replacement. It's very easy to use.
So you're standardizing these measurements only in the fingers? Are you never using knees or earlobes or a central capillary refill time?
Sometimes 6, 8, I don't know, 1 year ago maybe, I was involved in a study by a group of Italian guys from the south, from Sicily, and they are anesthesiologists. And the big problem is for the anesthesiologists, because in the OR, it's sometimes difficult to access the fingers, because these guys, the surgeons, they don't cooperate because they cover the field. They don't allow the poor anesthesiologist, to access the hands of the patient because the surgeon is there, So they have more problems. So they started to look at the earlobe, and we did a work in healthy volunteers, and they are now progressing in a study comparing both assessment in the fingers and in the earlobe. At least in healthy volunteers, they appear to behave similarly. This is another place where you can assess, and Hafid Autaufela, the guy that described, my friend that described the Motley score in Saint Antoine in Paris, France, he also has done work with capillary refill time in over the knee, and it has a slightly different cutoff. It's slightly higher. I have a friend in India where people have very dark skin, most of the people, and sometimes it's difficult to assess capillary refill time in dark skin. And he has been doing this in the tip of the nose, and he's making a study because this is a place where you can do it also. So, I mean, there are other places because the most used is the finger, but it's not the only place. The only thing that if you do it in other places because you cannot access the fingers or the hands, then you can do it, but obviously with a pragmatic approach, not a standardized, but you can have a sort of qualitative assessment. You press and you look, and always you have some clue at least.
Absolutely. I do have a question about modeling versus cap refill time. I love assessing for modeling and cap refill time. Sometimes I notice they are discrepant, where a patient might have more modeling, more cap refill time. How do you conceptualize them? They're both cutaneous measurements of perfusion, but sometimes they can be slightly different. Do you have any reason why that would be the case?
Yeah, I think they are different. I mean, capillary refill time is, from a physiological point of view, it's much simpler because, as I said, it's mostly flow. And eventually other aspects like vascular reactivity, etc. But it's mostly flow. And as it is flow, this has a big virtue, which is the kinetics of recovery. This is one of the things that I love most in capillary refill time. There is this work from Hafid, our friend Hafid again, and we reproduced this work last year, where he gave 500 mL of fluid bolus, and he performed a pharmacokinetic study, let's say a sort of pharmacokinetic study, or kinetic study, assessing capillary refill time every 2 minutes after the fluid bolus, every 2 minutes. He did this in 29 patients, and 23 were responders. He defined responsiveness as a decrease in capillary refill time more than 0.2 seconds or something like that. And anyway, that doesn't matter. But in the 23 responders, they got a significant improvement in capillary refill time at 10 minutes. 10 minutes. 10 minutes. And then in addition to that, Matthias Jacquet-Lagresse in Lyon, in France also, he performed this passive leg rising maneuver to predict the response of capillary refill time to a fluid challenge, a subsequent fluid challenge. And he did this in around 40 patients, I remember, if I remember well. And patients that increased capillary or improved capillary refill time with this passive leg rising by more than 23% and improvement. And this, he's a technical guy, Matthias Jacquet. He assessed it by an optic device, technology, an optic device, taking videos and assessing ex vivo, blah, blah, blah. And people responded during the 3 minutes. You know what I mean? He performed the passive leg rising, and for 3 minutes, and during this period, capillary refill time improved in around half of the patient. And then he applied the fluid bolus, and it reproduced what happened with the passive. This means that the passive leg rising, I am anticipating what you are going to comment about micro coupling. It probably is a test where you can assess that probably the system is connected, is coupled, because you simulate an improvement in flow, blah, blah, blah. Modeling is another issue. Modeling, because it's more complex. I have spoken with Hafid many times. He was in Chile last year, and he has done a lot of very nice physiological studies with thermal graphics, and it's more about microcirculation, a more diffuse aspect of the microcirculation, stagnation. It involves more complex aspects than simply flow. This is what he thinks, and I agree with that, because modeling disappears not so fast. Actually very slowly compared to capillary refill time. So, in other words, modeling reflects profound hypoperfusion of the skin, probably with a mixed mechanism that affect not only flow, but the microcirculation in general, the network of vessels and veins, etc. And it probably reflects a more severe disease. And from a practical point of view, you can, but you should not. And let's say, for example, you have modeling 4, and you apply a fluid bolus, and you expect in 10 minutes modeling to disappear. This will never happen. It takes more time. So as a resuscitation goal, it's not so, let's say, optimal as is the capillary refill time, but it's complementary. We use both. And in all our studies, we assess both, of course.
I like that you mentioned the microcirculation already, because that's some of our greatest questions are directed towards this subject. And I remember, like, back in the 2000s, the earlier studies with infrared, near infrared spectroscopy, looking at sublingual vasculature in patients with sepsis, where it's clearly shown that, for example, as compared to patients undergoing cardiac surgery who have normal microcirculatory sublingual perfusion, the patients with sepsis usually have a severely deranged perfusion, especially of small vessels under the tongue. And there's a classic study by, I think, Gustavo Espina Tascon, who performed fluid challenge or fluid bolus in patients with sepsis and looking at whether this improves the microcirculatory dysfunction sublingual near-infrared spectroscopy. And he showed that in the early phases of septic shock, what I mean by that is 0 to 24 hours, there seems to be a coupling of the macro circulation to the microcirculation, and you can easily improve the perfusion of the sublingual capillaries. Whether when you take patients that have more advanced sepsis, and that's what I mean by that is more than 48 hours, no matter if you improve cardiac output, you have a fluid responsive patient who you gave fluids and you have a greater than 10% increase in cardiac output, the microcirculation microcirculatory perfusion is not usually improved. And then there's where this concept I think you coined of hemodynamic coherence is really important. And my understanding of hemodynamic coherence is that any intervention you do to improve macro hemodynamics will end up improving micro hemodynamics. But by that, I don't only mean sublingual, but really all capillary perfusion in every tissue. And that might be also true for the capillary reflex time. So, capillary refill time. So I would like to ask you about your understanding of hemodynamic coherence. Is really this the goal of our interventions to increase perfusion? And should we be aiming not to increase cardiac output really, but really to increase microcirculatory perfusion, especially in the early aspects of sepsis? Should we be doing some dynamic tests, as you said, giving fluids and see if that increases perfusion, and not really seeing if that increases cardiac output? I think you have referred to this as a hemodynamic coherence test. So I'd like to probe your brain on all these thoughts and give us your insights into the macro and microcirculatory coupling.
Yeah, I mean, our thinking about this subject is based on this conceptual pathophysiological model, which is actually true. I mean, nobody discussed this, that during early septic shock, this is what I call the humoral phase of septic shock, or if you want to name it, acute sepsis-related acute circulatory dysfunction. What happens is that the early mediators circulate, and then they produce a profound decrease in vascular tone. But not only in the arterial side, where they cause hypotension, of course, but also in the venous side, where they cause a decrease in the pressure for venous return, in the stress volume, etc., and a decrease in preload and a decrease in cardiac output. So in the early phases, when you start with this first circulation of mediators, you can have this very acute decrease in systemic flow because of falling cardiac output and also fall in mean arterial pressure, perfusion pressure. But in this early stage, where many patients arrive to the emergency department in this early stage, especially if they had good access to the let's say health assistance, etc., you see that the macrocirculation is down, but the microcirculation is because of the fall in cardiac output and in mean arterial pressure, the other as a consequence. But when you restore perfusion pressure with early norepinephrine, for example, or cardiac output with fluid loading, you rapidly improve microcirculation, and because they are coupled, because they are not inflamed, and all these perfusion-related variables, they move in parallel in general. This is what we call the flow-sensitive stage. But uncoupling, this is the classic model of uncoupling or loss of hemodynamic coherence, which is the same. When patients arrive later on in the disease or more aggressive disease, it's progressive microvascular and endothelial inflammation, let's say, develops that affects profoundly all the endothelium, and particularly in the microcirculation. And then the microcirculation becomes plagued with sticky red blood cells, leukocytes, platelets. There is a leak to the interstitium, edema in the interstitium, a great heterogeneity of the flow in the microcirculation. And then it goes practical shunting. And when the shunting just progresses, then it is a decrease in flow when you assess microcirculation and the tongue, which we did for 20 years almost. You see a decrease in some variables that are calculated, microcirculatory flow index or proportion of perfused vessels. They decrease. This is convective flow decreases, but also diffusion, because the interstitium is wet and full of aggregates that do not allow oxygen to diffuse. So there is a severe, the more time, more time goes by, then it can get more severe. And finally, in the most severe cases, the microcirculation in different territories, this is not homogeneous. In different territories gets shunted. So this is the real uncoupling, real loss of hemodynamic coherence macro-micro, meaning that if you resuscitate, and you increase systemic hemodynamics, systemic blood flow or pressure, you do not get a reperfusion because there is uncoupling. And this is a very complex stage, because when you, in a desperate attempt, you start giving more fluids, what will you lead to? It will lead to venous congestion, and this will, let's say, worsen all this process, and finally, it will conduct you to the tomb, to death, because finally, you cannot recover this way. When they ask me what you have to do when a patient arrives in this stage, and a patient was first resuscitated in another center where they gave 10 liters of fluids and is fluid overloaded, full of venous congestion, full of microcirculatory dysfunction, I think in the team and make a ultrafiltration or some rescue therapy. We use there are different techniques at this stage. We used high volume hemofiltration in my hospital for almost 20 years now. But of course, if you are in other parts of the world, you can use other things like cytokine removal, plasmapheresis. There are many techniques. It doesn't matter for this discussion. But the solution is not to keep pushing the macro hemodynamic, but you will get things worse. This is what we should know about the problem. And but if, and I will show another here. If you it will be very important to know beforehand if the patient is still coupled or is just uncoupled. Because when the patient arrives first to your hands, to your resuscitation theater, let's say, because patients arrive to the hospital or to the ICU sometimes with, let's say, hypotension or epinephrine requirements, lactate, bad peripheral perfusion, not producing urine, whatever, acidotic, etc. But you don't know. Maybe they are in the couplet phase or uncoupled, and the management is different. So a simple test will give you clues. This has been our hypothesis. For example, what we did, and we published just recently our results, it's we applied to this patient that look similar, a fluid responsiveness test. And if they are positive, we gave a fluid challenge and looked at capillary refill time and several variables. Some patients that in the next half an hour or 1 hour tended to recover capillary refill time, we conclude that they are couplet is a hemodynamic coherent test with flow. But in other patients that were fluid unresponsive, we performed what we call hemodynamic coherent test with pressure, meaning a MAP challenge. A particularly fluid unresponsive patient, and let's say reinforcing indication for this, if this patient were previously hypertensive, and then we increased norepinephrine doses until reaching a MAP of 80-85 for 1 hour, and we look at the same perfusion variables, etc. And some patients recover, but some patients do not. They are tests. And I want to emphasize that one because a test, for example, this is where our results in this study that we published just recently. With the fluid challenge, almost everybody recovers very fast. This the individual behavior. This is a small clinical physiological study. And you see, starting from 0, almost all patients tend to improve capillary refill time when they are fluid responsive, etc., blah, blah, blah. But with the vasopressor test, you induce a challenge of mean arterial pressure. Some patients tend to improve perfusion capillary refill time, and others deteriorate capillary refill time. And this is very interesting because some years ago, Arnaldo Dubin, you know, from Argentina, which is a very nice scientist for the world, I would say, he performed an elegant study assessing another microcirculatory bed, which is the microcirculation under the tongue, which is another bed, but behave closely. They are, I would say, not similar, but they are not so far. This microcirculation under the tongue, and so he assessed it, and then he increased for periods of half an hour, mean arterial pressure from 65 to 75 and to 85. And he kept assessing microcirculation under the tongue in these time periods after this rises in norepinephrine and in MAP. And what he found is very interesting because he found that patients who had a bad microcirculation at baseline, when he increased MAP from 65 to 85, they tend to improve. And conversely, patients that had a good microcirculation at baseline, some of them deteriorated when he increased norepinephrine, etc., to this. So this is very interesting. It's all, I would say it's not the same, but it resembles our findings. Some patients improve, some patients deteriorate. Why does this happen? I think we have a preliminary, let's say, hypothesis is that in some patients, the increase in MAP over the effect of norepinephrine increasing the vasoconstricting the arteriolar sphincter, let's say, this play between the increase in MAP, which should be favorable, but if norepinephrine increases MAP, but produces a too much severe vasoconstriction at the arteriolar sphincter level, then it is probably that the flow paradoxically decreases in the microcirculation, after this, in the territory that they call now the waterfall, you know? So this is what we say. But if the balance between the increase in MAP versus the precapillary sphincter is okay, then it may improve. This is from a hydraulic hemodynamic explanation that could be true, but nobody knows. But I have to add something very important, especially for young people, because this has been, you are young people, of course, for you all are not young people, it has been a long controversy in clinical trials, let's say, which is the best MAP goal for septic shock. And you know, there have been some major trials, the ASFAR trial, the La Montagne trial, etc. They take 1,000 patients and they flip the coin. This guy 85, this guy 65, without any consideration. They maintain this MAP goal for 5 days, and they look at the kidney function, they look at blah, 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 blah. No physiological test, nothing. So all these trials have been neutral or have had contradictory results, you know. But no of these trials have shown an improvement in major outcomes. But what we think is that if you, instead of doing that, you apply a test in hypoperfused patients that are, for example, fluid unresponsive, previously hypertensive, and what do? You cannot give fluids. Why not try an increase in MAP, but as a test? This is the beauty, a test for 1 hour. In 1 hour, And if in 1 hour, looking at capillary refill time, and that is the beauty also that it recovers so fast, you see a recovery, then you are in the right track, and then you can maintain this higher blood flow. But if it deteriorates, just you return to 60, 65, because you can be harm the patient. No, this is what the consequences of this kind of thinking.
That totally makes sense to me. And I think that ethos is reflective of Andromeda Shock 2 and the protocol in general, where it's, hey, let's check correct cap refill. If we'll try something, if it works, we'll see it get better. If not, we'll try something else, and we'll go through kind of a physiologically informed pathway. So that totally makes sense to me. I guess in the last few minutes here, how have you found different hemodynamic interventions impacting cap refill? For example, fluids, vasopressors, inotropes. And do you have just any insights from the Andromeda Shock 2 protocol and all the work you've done designing that, and then also kind of now running it on well over kind of 1,000 patients here? So yeah, I'd just love any comments on that kind of as we're wrapping up, any take homes that we can apply at the bedside.
Yeah, I would say the 3 interventions, just to be briefly. With fluids, I think the vast majority, and there have been 4 studies now, 4 small studies like our last one, that gave fluid challenges, boluses in fluid-responsive patients with abnormal capillary refill time, and all these 4 studies have shown that the vast majority of the patients respond. Capillary refill time tend to improve. In some patients, keep neutral. And I have seen no data that one patient has deteriorated with fluids, with the fluid challenge in this setting, So it's relatively safe in this setting. Norepinephrine or rising MAP, a MAP challenge, as I said, some patients deteriorate. But the beauty of the challenge is that when it happens, you can return to 60, 65. That's this. And in Andromeda, the last step of the algorithm is the dobutamine test, with small doses of dobutamine. And this is also the heritage of a long thinking that dobutamine in low doses, even this is what the old physiologist said, even in doses lower than doses that increase cardiac output, they exert this vasodilatory effect, and then they could eventually improve capillary refill time. The same was said for microcirculation under the tongue. Previously, in the 90s, it was said for gastric tonometry. The people that believe that small doses in dobutamine could improve tissue perfusion in doses even that do not produce a major impact in the heart. But I am a little bit skeptic with that, because we now know that there are some cardiac phenotypes that are harmed by dobutamine. For example, the hyperkinetic heart, the persistent hypovolemic heart. So I would not do that, except I have a nice echocardiography ruling out a condition that could be impaired by dobutamine. But this is the mechanism. When I tell this to my Dutch friends, in Netherlands, they are very special because not only for the cheese, but also because they love vasodilators, nitroglycerin and others. And they say, why don't you use nitroglycerin to improve? That's another matter.
Well, I think that's a good question, though. What do you think the role is of nitroglycerin or other vasodilators in septic shock? Could we improve coupling of certain capillary beds, particularly as you alluded to with the vascular waterfall and the vasoconstriction of that afferent arteriole? Could we improve that coupling with it? And is there a role for that in future studies?
I think that eventually, yes. My answer would be that eventually, yes. But we need a lot of more clinical physiological studies, now that we have more tools, because I was saying today before this meeting started that until now, we said all the responsibility of macro, micro, and coupling of loss of coherence was in the inflammation of the microcirculation. But now we have tools to assess microvascular reactivity with this vascular occlusion test, and you see how the endothelium behaves. And we have also some techniques to assess the waterfall at the bedside. You know, it's not so easy as we can say, drink a glass of wine and say, oh, let's assess the waterfall. Yeah, the inspiratory hold. It's easy to say, but it's a little bit more complex, but you can do it. And I think we will recover more and more info in the next years about how this third actor, let's say, microcirculation, inflammation in the microcirculation, microvascular reactivity, and the interplay between macro hemodynamics and the micro hemodynamics, this waterfall, closing pressure, etc. And maybe these are three pieces that are important, you know, but we don't know yet. When I have a clinical model, and we apply, I told you we are applying to a grant to study these three things simultaneously in response to a fluid challenge, and then if we do this and we have the model for clinical visual, then maybe we can apply vasodilators like nitroglycerin and to better understand what is going on, because otherwise we will go blindly, you know, and then we will never learn.
Yeah. Well, thank you so much, Dr. Hernandez, for joining us today. And yeah, it's incredible to see the work you're doing. And you know what, seeing Andromeda Shock 2 recruit at over 100 centers worldwide, multiple continents, and just kind of the commitment for you and your team and trying to improve care for patients with sepsis around the world, and not just in ivory towers, but in every emergency department, every intensive care unit in the world. It's incredible to see in your commitment and your team's commitment. A lot of people might not know that you actually started Andromeda Shock 2 without a massive grant or anything. This was done purely based on your team's commitment,
enthusiasm.
Enthusiasm and just collaboration and the relationships that you've cultivated over the year with your research and commitment. So I've felt very, very privileged, and I'm sure Eduardo would say the same, to play a small part in the study and to be part of your team. So thank you so much for coming on today and for all the work you're doing.
Thank you.
Thanks again.
It's such a fun, no? I mean, it's so fantastic to speak about these things. I would have stayed for 1 hour more, but anyway, it's fantastic. Thank you very much for inviting and for the idea.
Thank you, Ross, for this amazing opportunity to talk with one of the greatest in the world of critical care.
Thank you very much. Thank you.
Thank you.
Thanks everyone online.
Bye-bye. Bye-bye.
Yeah. All right. Take care.